Welcome to another PrecisCa tumor board. Great to have a world-renowned faculty to discuss these cases. I'm Dr. Benjamin Levy. I'm an associate professor at Johns Hopkins School of Medicine and a thoracic medical oncologist. And again, joined by a wonderful group of faculty. I'm going to allow them to introduce themselves. We'll start with Dr. Bala.
I'm Sanjeev Bala. I run the cardiothoracic imaging section here at Washington University in St. Louis. It's good to be here.
My name's Wally Curran. I'm the Chief Medical Officer globally for Genesis Care and Professor and Director Emeritus of the Winship Cancer Institute of Emory University.
I'm Varun Puri. I'm a thoracic surgeon and professor of surgery at the Washington University in St. Louis, along with Dr. Bala.
I'm Ross Camage. I'm the Director of Thoracic Oncology at the University of Colorado. I'm a medical oncologist and delighted to be here again.
This is an 87-year-old male, former smoker, 20-pack year history, with a history of advanced stage adenocarcinoma of the lung, received 4 cycles of pembrolizumab with progression of disease, then has a documented BRAF V600E mutation and receives dabrafenib, trametinib, but now has further progression of disease. Question is, if progression of disease, what is the next best treatment as third line for this patient? So the patient, again, 87, a former smoker, presents in July 2018 with dyspnea on exertion, slight fatigue, no cough. His performance status is unknown. I think that would be important in an 87-year-old. His medical history: hypothyroidism, arthritis, gout, COPD, and BPH. Again, 20-pack year history. He quit 30 years ago with no drug or alcohol use, and he has no family history. His chest x-ray shows a left pleural effusion, and I'll let Dr. Bala go over his chest CT.
Thank you, Dr. Levy. So the chest CT confirms that there's a small to medium-sized left pleural effusion. And though this is a lung window, if you look along the posterior surface, you can see that there's some nodularity. And so it's very suspicious that we're dealing with a malignant pleural effusion.
Okay, so the patient has a thoracentesis and the left pleural fluid is consistent with adenocarcinoma, but there's not enough for NGS or PD-L1. He's 87. We don't know his performance status. And I would just ask, the potential discussion to do further assessment to get tissue. Let's say the PET scan does show some pleural nodularity. Dr. Puri, would you hesitate on going in and doing a VAT biopsy to get more tissue if the medical oncologist was wanting more tissue for NGS and PD-L1? That clearly makes a difference for some of these patients. Your thoughts on this and your approach in someone in their 80s on whether that's a reasonable approach?
Thanks, Dr. Levy. This is a very commonly encountered situation in most thoracic surgical practices, including ours. And what we essentially want to try and do in this situation is to both palliate the pleural effusion as well as try and obtain tissue at the time. And a very reasonable approach, depending upon how frequently the effusion has need to be drained and sort of what the functional status of the patient is to do a thoracoscopic evaluation with a brief operation under anesthetic, whereby you will both obtain tissues with biopsies in the operating room and either perform a pleurodesis depending upon what the lung expansion is and what the function status of the patient is, or place a long-term indwelling catheter such as a pleurex catheter. So it's a rather common request that we get, and we generally, this is the approach that I just described is the one that we generally take in these situations.
Okay. So we don't know if that was offered here or not. It doesn't sound like it was, and maybe the patient declined. 87 may not have been a fit. We don't know that may not have been able to tolerate it. We don't know the performance status of the patient. This is the PET scan. I'll turn it over to Dr. Bala just to review it.
So the FDG PET is incredibly helpful, I think, because it shows this area of uptake that's in keeping with the more metabolically active components. And I know with Dr. Puri and us here in practice that occasionally with these difficult pleural lesions, the role of FDG PET is that it can help localize where to target for biopsy or for a thoracoscopic intervention. I will say, though not performed here, MRI with contrast in a center of excellence can also be very useful for the same indication to help try to find the nodules in the pleural surface because they are scattered. It can sometimes be really hard to find to biopsy.
Okay. So it looks like there's some pleural involvement here on the left hemithorax. And again, this patient undergoes, again, a thoracentesis with improvement of symptoms. There is a liquid biopsy performed on the patient, because remember that thoracentesis did not have enough cells for next generation sequencing to be done, or even PDL1. So plasma genotyping is done that only shows a P53. The decision is made to give this patient 4 cycles of Pembro. We don't know what kind of discussion went down, whether the patient was chemo averse. We don't have a PDL1. The patient is 87. He's a former smoker. And so patient receives 4 cycles of this, and these are pre-treatment and post-treatment scans. Dr. Bala?
So the post-treatment scan highlights with this red circle an area of recurrence that is in the chest wall musculature anteriorly. And so though the effusion hasn't changed very much in size, we've now got this new soft tissue recurrence of the chest wall.
Okay. So there is progression here. And so the patient does finally concede to a CT-guided biopsy, core biopsy, that does note a BRAF V600E mutation. The other alterations are, of course, not detected. He's initiated on dabrafenib and trametinib, and these are the pre-treatment and treatment response that we're seeing here.
Yeah, so the pre-treatment image, again, shows that soft tissue nodule. But if we look on the post-treatment, it looks like there's increased nodularity of that pleural surface, and that area still has that soft tissue nodule with some increased adjacent soft tissue nodules. So the soft tissue components have increased on the treatment response image.
Okay, so the patient did remain on dabrafenib for some time, 100 milligrams twice daily. It was dose reduced due to rash and fatigue, and remained on the 2 milligrams of trametinib daily. But as Dr. Bala mentioned, there was eventual disease progression. So a couple of questions here. I want to turn first to Dr. Kamage. For the initial management, so this patient had pleural fluid removed, the cytology was positive, but there was not enough for NGS or PDL1, 87 years of age. Let's say he's got a reasonable performance status, but doesn't want any additional procedures done. How would you have managed this patient up front? And then we can talk about what to do in this scenario where he's at now.
Thank you, Dr. Levy. Honestly, I think the physicians here should be commended, because although it was challenging, they didn't let the idea of getting molecular information fall by the wayside. I mean, they went for plasma genotyping, which gave them an uninformative result. We know that often thoracic-only disease will less commonly shed DNA that's detectable in the blood. And then they went for a CT-guided biopsy. So they actually did all of the right things. Your question is, should they have started with the pembrolizumab or repeated the biopsy earlier? I mean, I think that depends on, the mindset of the patient and how easy it was to do. With the recurrence in the chest wall, obviously that was probably the area that they went after with the biopsy. So they were given a little bit of a gift later that probably made it safer to biopsy. I'm very comfortable with what they did. I think the surprising thing is, I agree with Dr. Bala, when you look at that scan, which says treatment response underneath it, it doesn't look like the patient actually responded, and yet they stayed on the therapy. And I wonder if that's telling us something about the fitness of the patient for changing plan, and maybe something is better than nothing. Let's imagine the patient were fitter, though. I think one would be thinking about chemotherapy in this setting. They've already tried immunotherapy. The mechanisms of acquired resistance in BRAF V600E are, despite being known for many years, poorly described in terms of actionable changes. So we really are down to systemic cytotoxic chemotherapy. But I would want to think outside the box. I think I would, for somebody who really only has pleural disease and then that chest wall disease, I would go to Dr. Curran about possibly irradiating that chest wall disease. And I would go to Dr. Puri about managing that pleural space to stop the fluid building up.
So both excellent points and nice segue to some questions. So let's turn this over to Dr. Curran first. Dr. Curran, is there a role? You've got a patient who's got, cytology positive pleural fluid, it's drained, but there's pleural and chest wall disease only, 87 years of age. Is there a role for radiation in this patient, and how would you manage that?
Yeah, great question, Dr. Levy. It really depends on what the therapy is. Radiation is not very good for managing bulky pleural disease other than in patient. Not really a very good therapy for preventing reaccumulation of pleural fluid. If, on the other hand, there's a large region of pleural-based mass, which could cause mass effect or greater pain, a very brief course of radiation in the patient's situation could be reasonable.
Okay, and Dr. Puri, just one more time, your management of this surgically for recurrent pleural effusions and pleural disease only, how the surgeon approaches this if that's the only site of disease?
I think in someone who has metastatic disease in the pleural space, and it's not a mesothelioma, then we think essentially palliation, Dr. Levy. And there are three modalities with which one can palliate them: either a bedside pleurodesis, an operative pleurodesis, or placing a long-term indwelling catheter. And there has been a lot of work that has been performed, both retrospectively and prospectively, some of it by our group in this domain. And we assess how frequently is the effusion building up, and what's the performance status and expected long-term or intermediate-term outcomes that this patient would have. If the patient is otherwise fit and the pleural has had reasonable response or is expected to have reasonable response to therapy with an expectation of years of survival, then generally speaking, our approach is to perform an operative pleurodesis. An operative pleurodesis is more effective than a bedside pleurodesis and avoids the long-term potential issues with a long-term indwelling catheter. So that's how I would approach someone who has reasonable intermediate to long-term outcome. However, in someone with either poor performance status or where we think that the likelihood of long-term survival or intermediate-term survival is relatively low, then a long-term indwelling catheter or pleurex catheter would be our preferred strategy. In addition to this, the one point I'd like to make is that we see a number of these individuals who have unfortunately had many thoracentesis done over a period of time, as and when they become symptomatic. And when we eventually intervene on these individuals, they unfortunately have trapped lung, which Dr. Bala and I discussed several times on imaging studies. So they are unable to benefit from an intervention to evacuate the fluid because the underlying lung will never re-expand to fill that pleural space. And generally speaking, our recommendation is to intervene early. So as soon as one has had one or two thoracentesis and there's a likelihood of the pleural effusion reaccumulating, then we should go ahead and perform something to keep as much lung recruited as possible.
Okay, so excellent overview from each of the disciplines. It sounds like for this patient, potentially moving forward, certainly chemotherapy, if they're fit, post pembrolizumab and post BRAF-directed therapy, chemotherapy seems like a reasonable strategy. Doesn't seem like radiation is in the cards for most patients with large volume pleural disease, but a consideration for an operative pleurodesis or long-term catheter from the surgical perspective is also important to consider in this case.